As health systems are reconstituted after conflict, there are opportunities to modify health workforce policies and practices, including health work incentives. Our research under Sub-Study 2 was designed to enable us understand the post-conflict dynamics for health workers and what form of incentive environments best supports rational and equitable health services. Throughout the research process, ReBUILD researchers have been engaging with stakeholders from government, development partners, academia and civil society to ensure that ReBUILD activities are relevant and support processes to develop the health system in post-conflict northern Uganda. In February 2015, a second validation meeting for the ReBUILD project in Uganda was held with the following objectives. 1. Sharing preliminary findings from all ReBUILD sub-studies. 2. Pre-testing messages with the district audiences. 3. Receiving feedback on the various project findings. And 4. Formally flagging off data collection for Phase 2 of Sub-Study 5, focusing on aid architecture. The one-day meeting, held at Churchill Courts, Gulu town, was attended by participants including district health management teams, health facility managers of private, not-for-profit and public facilities, health workers and representatives of selected NGOs from Amuru, Gulu and Kitgum districts. Introducing the ReBUILD project, the Uganda team leader, Associate Professor Freddy Sengoba, said the ultimate desire of the project is to contribute to the development of pro-poor health systems in the country. On behalf of the Gulu District Health Officer, the acting DHO, Dr. Robert Ongom, noted that ReBUILD provides a broader package of research, unlike projects that focus on healthcare alone.
An effort like this to understand the service delivery, especially health service delivery, is very important if we are going to make meaningful rehabilitation or reconstruction of Gulu. I appreciated that it's quite holistic. It's not only the usual scope where we tend to understand health service delivery in terms of the healthcare itself.
Sub-Study 2 focuses on health workers' incentives to attract and retain health workers in post-conflict northern Uganda.
We found that there are various human resources for health challenges in this region, and those were clustered into 4 major clusters. We had the recruitment challenges, distribution challenges, retention challenges, and those that are related to the performance of the health workers themselves. So we're more interested, as I said earlier, in the evolution of these challenges. We found that recruitment challenge is actually very eminent in the conflict period, and that is necessary. That was exacerbated by the security situation. But then, when you ask them what happened after the conflict to the recruitment challenges, they said that it had improved a little bit because of the improved security situation. But the other challenges actually that came up, that they mentioned that are leading to the recruitment challenges. And one of them was about the training institutions. As we're all aware, most of these districts actually have training institutions in the various PNFP facilities. And some of them are producing particular cadres and not others. So some districts like Pade, for example, it only had midwives, and the others did not have. And the other challenge they mentioned was the recruitment ban. Districts are willing to recruit more health workers, but some of them, before they even passed out the advertisement, the ban came up and it hindered the whole process. That's what happened there. And then we found out something more interesting about the competitive labor market. The key woman said that the recruitment is done at the same time, adverts are put at the same time, so health workers are able to apply to all the districts they want, and actually do interviews everywhere. So you find that some districts actually have so many people who do the interviews, spend so much money, but then when it comes to recruitment, people will go to where they desire most. So you find that people like Gulu, for example, people who are in Gulu are more favored. Districts like Gulu are more favored than others, as we later see. And then the poorly focused recruitment. Prof talked about the issue of askaris, having many askaris and shama boys in many of these facilities. We found that there is recruitment being done, yes, but the cadres are being recruited actually are not related to the medical field. They're out of the medical field. So as you're saying that we're recruiting more health workers, are those health workers or their support staff of the health workers? And then the lack of funds and delayed funds for the recruitment process who came out as a very big challenge to the recruitment of those workers. And these are some of the voices. As you can see, this is a key format from Padea district. We're talking about the challenge we had with the other cadres. They only have, mainly they have midwives, so the nurses are not there. And that is affecting the staff mix as we later come to see. And then we have the recruitment ban here in Amuru. I know that it's still the same case. We'll get updated on that. And then this is, we found this as the most emerging challenge for the region. And as I'll later share with you the policy briefs, probably we'll find out what we can do about this particular challenge. Again, Doctor talked about the mix, if I could recall his words in particular, talked about the mix of the cadres as being poor in the region, and that's what we called them. And the problem was during the conflict actually, many people ran away for their lives, most of them died, and just because the rebels were actually looking for them to do the work for them in the bush, as you can see there. So we found that the numbers were low. At the same time, the health workers were very few again, as you can see here. We have nursing assistants manning health centers. So the staffing mix, even the quality is questionable in some of these facilities. But after the conflict, what happened? We expected that, or we hypothesized that, when the peace returns, the health workers will also go back to the facilities. That wasn't the case. So the challenges still remain. The nursing assistants, most of them are still there, and other lower cadres, and more qualified staff. The doctors, the clinical officers are missing in the facility. And then the issue of Southern Sudan came up as eminent in those interviews as well. They were saying that people were running away and going for greener pastures. Apparently, in South Sudan, they are paying better than we are paying. And since the borders are very porous, anyone can go at any time. And the other issue is about the new administrative units. We found that districts are being created every now and then. If you found that, if you looked at the region before, it was only Kitgum and Gulu, is it? But as you found later, the districts began being split and split and split. So what happened? Dr. So-and-so moves away from the clinic or the health facility setting and goes and becomes DHO of Paddy. Dr. So-and-so moves away from this hospital and goes to open up Moya district. So we find that we are siphoning our own health workers. If you are complaining we don't have health staff, but we are the same people who are killing the distribution. And then the NGOs, many of us, because of the poor pay probably, they are moving away from the bedside and joining the lucrative business of the NGOs. Yes, they are very good, but our solution faces a problem. So it's a complex situation. And then recruitment challenges. During the war, I again emphasize, security situation affected retention. As I mentioned earlier, people are running away. As someone is saying here, although you promise to die for the people, you can't die when you're just seeing death coming. So they are human beings. Yes, they're health workers, they swore to the oath, but they're human beings. So if you're protecting the civilians and leaving out the health workers, don't run away because they also need their lives. And we found that the epidemics like Ebola, remember we lost one of our key staff in Lacho to Ebola. So most of them said if that specialist can die, who are we to stay? Some of them ran away to better to another area. And then after the conflict, what happened? The challenges remain. They're less pronounced, but they still remain. And one of the reasons, as I already said, was the departure of NGOs. When the NGOs, most of them were looking at short-term, apart from APSI, sorry, looking at short-term deliverables. So, and they're not mentoring in the sense. So when the war ended, most of them moved away to Southern Sudan. They were moving, apart from that, there was a few that are remaining. So what happened? Some of them had seconded staff to work in the facilities. And when the NGOs left, these facilities couldn't afford to pay these people the same salaries that the NGOs were paying them. So what happened? They laid them off. And in this case, it means that there is no sustainability plan in some of these programs. Another thing was about social amenities. I know this is not so only looking at northern Uganda, it is everywhere that those workers are lacking social amenities, the schools and electricity and good water for their families. But it's also emerged as one of the issues that was making them run away to other areas. So those are some of the voices from the key informants. You can see Kitgum has lots of issues in terms of retention of the workers who are there, and also in terms of people running. Maybe the border is near. I'm not so sure. Yeah, I don't know. Is it? Yes. Okay. Then during the conflict, the salary was low in most cases because some people actually, the banks were in Gulu, if some of you could remember. So it was, they were absent, low because it has always been low, inconsistent because it was hard for you to travel from Kitgum or Pade to come and get your salary here, but also absent in some of them because there was a blockage of the professional support from the national side because of the insecurity and the ambushes. So what happened after the conflict was the salary is still low. One, as we have emphasized before, the cost of living has always been increasing. If the salary is still the same as it was, and the cost of living is increasing, then it becomes meaningless for some people. But some of them mentioned that, or most of them mentioned that, whereas they went ahead and had further qualifications, they have not had their salaries improved to match their qualifications, and that caused demotivation, and therefore affected their performance. We also realized that there is affirmative action. People from national level and people, national level in particular, if you're happy to hear, mentioned that actually sub-region needed affirmative action after the 25-year or so conflict that they experienced. And so we find that some of these initiatives that came up were in line with that affirmative action. So that the post-conflict period then created a window of opportunity for such initiatives. And the voices of key informants have highlighted that the allowance was actually wound dressing, a drop in the ocean, as some mentioned, and it was so low compared to the cost of living. Again, cost of living keeps on coming. And some of them actually didn't even know whether it stopped or not. And also issues with clarifications on what is rural, what is urban. Then also other policy response in relation to the recruitment. We have all heard about secondment of health workers from the government, but this mainly has been to the PNFP sector. And this came from an actually was saying that the government ends up benefiting more. They have to cater for themselves first before they cater for the PNFPs. So we still have some gaps there, but of course you know that if you're the one serving, you have to give your family first. Anyway, but you need to understand better. PNFPs have been here for a long time, and they have been supporting the health system. Yes, the government is trying to do that, but they still have challenges also with health workers, so they need support. The other response or initiative that came up was using personal networks to recruit health workers. So people keep on connecting one another, using their places and people they know to tell people to come and work in the districts, to lobby others to come. And then the salaries, like I said earlier, they need to be increased to match the promotion level and the cost of living. And then recruitment needs to take into consideration the gender balance. And The other lesson was about the need for sustainability. Yes, we're doing all these things, we're having all these ideas. We need to think about how long-term they are going to be, because the health system has to last even beyond the conflict or beyond the recovery period.
The study sought to understand the perception of key people of health work incentive policies. It also sought to understand the evolution and effects of incentives of health workers in post-conflict northern Uganda. Issues that were raised during the discussion included social amenities as major incentive, uncoordinated recruitment system, and labor market for HRH in the region, the effect of the recruitment ban and how it affected recruitment of health workers in the public sector, the need to engage donor and government agencies to establish a bursary scheme, bonding as a recruitment strategy, government strategy to export health workers amidst shortages in Uganda, attitude of the health workers, political interest in welfare of health workers, and review of health workers' wages.
Thank you, Chair, for giving me the opportunity. The findings are true, according to me, but I can add more reasons why they could have got the results. I've been taking up from the distributional challenges, things to do with social amenities. I cited from my district. You have a nursery child, pupil, who should also attend lessons at a better school, you being a civil servant, and you are posted to a village far away from where you are.
The reconstruction activities in post-conflict northern Uganda represent opportunities to rebuild the health system. The government and international community have, however, provided additional financial resources to address different constraints in the health and related systems. The ReBUILD Consortium will contribute research evidence to help optimize these opportunities for health system development.